like to do is to send out two messages. One is make you aware of how we as an institution think about AI for social good, what we actually mean by creating social good through AI, which is somewhat different from how it's done in the West. I mean, there's a notion of AI for social good in the West that's a bit different from the way it applies to India and more generally the global South. So I'd like to tell you a bit about how we think about these things and how we operate. And the second set of messages is really to give you a little bit of a flavor of the types of solutions that we are building. And mainly there, the idea is to motivate the problem, sort of try and show why this is an important problem and why AI can help addressing this problem, and then show you some of the initial results that we have. So we are a relatively new institute. We're about 2 years old, and we've taken on a number of very large problems of societal importance. So all of these problems are in different phases of progress. One might say work in progress, but in different phases. So I'll just start with sort of almost a definition statement. So we are a nonprofit research and innovation institute, and we're dedicated to building AI solutions for social good. So this is in contrast to maybe a policy think tank. We are not a policy think tank. We are actually interested in building solutions that will help underserved communities across the developing world. We are interested in some questions of policy, but that's not our main emphasis. We're not a pure research organization in the sense that we are not about only publishing papers. Although papers can be a byproduct of what we do, nor are we an organization that makes money. As I said before, our aim is to really create impactful innovations that are free for social use and that can scale. So these are sort of the broad domains of interest, where we see opportunities for large-scale transformation with AI. Healthcare and agriculture are the two domains we are currently working on, but we are also considering projects in education, in smart cities, things like sensor networks and so on, as well as financial inclusion. So this is how we work, or how we intend to deploy our solutions, the solutions that we create. Typically, we engage with various other nonprofits or with governments, sometimes even with corporate entities, to identify problems, to identify data sources, and so on. So that's the initial part of the cycle. Then we start working on specific problems, and there's a whole cycle of going through usability, product, tech POC, and so on, pretty much like a standard, like it could play out in a standard tech company. But then in the social context, it's important to have a pilot stage for the solution. And this is where things start differing from a standard internet or tech company. So we would have a pilot stage where we would scale it in a small way, and then look at the impact on our beneficiaries. And then again, we would have to partner with other organizations to achieve large scale, simply because we are a small institute and not capable of achieving large scale independently. So partners are really key to what we do. So the way we think about AI solutions for social good is that this is a small but important piece that sits within a much larger ecosystem. So there may exist social systems, either run by the government or run by NGOs. And then within that, we provide, within that, there is a solution space for a specific part of the system. And then within that is the product, and the product contains the AI component. So we see the AI component as being sort of one small but very important cog in the entire social context. And you'll see how this plays out in the solutions that I'm about to show you. So the first example I'd like to discuss is tuberculosis. I know we are currently in the days of COVID, and everybody's talking about COVID. That's also an area that we're working on, but I really wanted to highlight, and this has also come out in the news, recently that TB is a far bigger problem than COVID, and it doesn't have to be one, right? So if you just look at the numbers, right, just the pure numbers, in India every year there are about 2.75 million new TB cases, right? And you can compare these to the COVID numbers. There's about 500,000 deaths every year due to TB in India. And the corresponding worldwide numbers are 10 million and 1.5 million. So you can see that, you know, India carries about a quarter of the world's TB burden and about a third of the world's TB deaths, right? I mean, these are staggering numbers. Of these, you know, of these 2.74 million, about 1 million cases go unreported per year. So they're simply lost. You know, these are people who for various reasons are never treated. The more people die of TB than of HIV and malaria put together. This is true both in India as well as worldwide. Also, many more people die of TB than of COVID. COVID is a relatively recent phenomenon. All this is in spite of the fact that TB is curable, right? So there is a treatment regimen for TB. There's complicated TB patients that constitute a small percentage of the total patient population, but most of most people who suffer from TB can be cured. So what's the problem? Why are there so many people dying, right? Well, there's a range of problems all across the TB care cascade. One is lack of good diagnosis, and I'll talk about that in a minute. There's inaccurate, the first line screening for TB is either inaccurate or expensive, right? There's patient refusal for various reasons to stick to their medication regimen. And then there's side effects of drugs and so on. So all of these combine to, I should also point out, even before lack of diagnosis, it's sort of lack of awareness is a more basic problem. So these are the numbers I was showing you for TB. So this is sort of the TB care cascade. If you look at the red bar on the left, that represents, the population of patients, of people who are suffering from TB at any given time. And then there is a drop-off cascade to patients who eventually seek care. So the red bar on the left is the total number of patients. The bar on the right is the number of patients who are eventually cured, right? So there's drop-offs along the care cascade for various reasons. Initially, there are patients who simply don't seek care and therefore are not notified or not sort of never see a doctor for whatever reason. Then there are patients who see a doctor but are misdiagnosed or not reported into a central system. So, for example, the Indian government has a central repository of TB patients called NICSHAI, and every TB patient by law needs to be reported into NICSHAI. But for various reasons, private doctors don't report into NICSHAI. There are lapses and so on. So that results in another drop-off along the care cascade. There are patients who are diagnosed but never start treatment or are never formally registered, even though treatment is free in India. They simply never start treatment. There are people who start treatment but don't finish it. TB treatment is very sensitive to medication regimen. So if you don't finish treatment, you can sort of you can get what's known as drug-resistant TB later. And then there are sort of patients who relapse within 18 months of completing treatment. And then eventually there are patients who for whom treatment simply doesn't work, which is a small population. But this entire sort of cascade of drop-offs results in 1 million patients roughly being lost every year. And there are various points in this cascade where AI can help. So AI can help in finding patients. AI can help in creating better diagnostic tools for patients. AI can help in identifying patients who are likely not to take their medication, and so on. Right? There's a number of problems here that are addressable. So one of the problems we're working on, one second, is actually predicting treatment adherence in TB patients. So are patients adhering to their treatment regimen? So it turns out that, as I said before, TB treatment outcome is very sensitive to adherence to the regimen. If you miss for example, just 10% of your doses, that increases your chances of getting drug-resistant TB by a factor of 3. One way adherence is monitored and, in fact, encouraged is through a system called 99 dots, and you can see a picture there on the right, where you have a pill strip containing medication pills, and then when you pop out a pill, there's a phone number at the back, and all you have to do is call that number, and all you need to do is a missed call to that number, and then that's recorded as evidence that you've taken your pill. It's a very simple, free system. It's also very error prone, unfortunately. So it doesn't always record adherence to medication, but it's one way of measuring adherence, or at least measuring your engagement with the TB program. And in fact, for AI, this is really important because this provides interesting features for machine learning models, right? So all of these calls are logged, and these logs can be used as features. Actually measuring whether a patient is adherent to their medication turns out it's a very tricky process. You have to subject the patient to a urine test, and then the result of the urine test tells you whether they've taken the pill, taken their TB pill within the last 2 days, right? There's a proxy for an extreme form of non-adherence to medication, which is known as loss to follow-up, which is where patients simply don't take their medicine for 30 days in a row. So as an initial project, we tried to predict this proxy. And so these are very preliminary results. We are trying to predict treatment loss to follow-up in TB patients in advance, right? So given a patient, we ask, when they start their treatment, how well can we predict whether they'll eventually complete treatment or whether they'll be lost to follow-up? What about if you had 30 days of patient history in terms of these 99 dots call logs? Can you predict better? If you had 60 days of patient history, can you predict better, and so on? These are the types of questions we're looking at. And the curves that you see there are sort of precision at top K and recall at top K curves. And we find that as you know more about the patient, as you gather more and more history, you're able to better predict loss to follow-up. There's some baseline models where you just use the call records, and those are simply not very good. They're not better than predicting by chance. But if you actually use other demographic covariates like the age of the patient, the gender, there's some income-related covariates and so on, as well as other comorbidities if they have other diseases, their family size, where they live. These are all important features, it turns out, and the integrated model with all of these features, that's the purple curve that you see. It gives you a fairly large lift over the baseline prevalence. So this is a population. This test set consisted of a population of patients in which about 2.5% went LFU, and that's the black line at the bottom. And you can, if you target say 50 or 100 patients, you can get a fairly high hit rate. And this is still preliminary. There's a number of things that we are doing to improve these results. There's other TB applications that we are also looking at. One is sort of case discovery. Where do you need to go in India to find new cases that you may not have found otherwise? And that's really, it can be cast in some ways as an RL problem. And then that can be combined with planning at the central level. We are also looking at better screening modalities for TB, for example, with cough sounds. I mean, cough has turned out to be an important correlate for COVID as well. It also has interesting sort of TB features in it. The other problem area that I wanted to talk to you about is in agriculture. So the picture that you see here is really a cotton ball, and there's a worm inside the cotton ball that's called a bollworm. The interesting thing about this bollworm is that, even though that rots the cotton from inside, there's no visible effect on the outside of the ball, right? So it's very hard to detect unless you break open the ball. This may seem like a small issue, but in fact, it's a very important issue. India is one of the largest producers and exporters of cotton in the world. And 75% of cotton in India is grown by smallholder farmers. And one of the major issues in cotton farmers is farmer suicide. And farmer suicides can be mainly attributed to pest attacks. So Maharashtra, where our institute is based, is one of the top states in terms of farmer suicides. And these are some of the statistics. About 1,000 cotton farmers committed suicide in 2017, 2018, after pink bollworm attack destroyed 40% of their yield. And one of the critical challenges these farmers face is really inability to manage pests. Even though they have pesticide, even though the government gives them pesticide at discounted rates, they don't know when to spray, right? This is a major problem. So here's how the problem is currently solved. It's a very manual process. There's sort of, in every village, there's what are known as demo plots or demo farms, where they take pictures of pests on a trap. They manually count these pictures, count the pests on the trap. Then the pictures are uploaded into an app. The data is aggregated. It's sent to an agricultural university where there are experts who look at the pictures, who look at the pests, and then decide if it's time to spray. And this entire process of, the data going to the agricultural university, feeding back to the farmer, it takes a couple of weeks at least. By that time, the crop may be destroyed. So the question here was, can we sort of design a simple AI solution that can take care of this? So this solution, in fact, is fairly straightforward. You have on the demo farm, you have a pest trap. One example of a pest trap, the one I've shown you here, the yellow one is a sticky trap, and all kinds of things stick to it, including the bollworm pests, the pink bollworms, as well as other types of dust and so on. So the challenge is really to identify. There are two challenges here: to identify how many pests there are, and the second challenge is, given how many pests there are, what's the density of pests on the farm, and therefore, is it time to spray or not? So the second part of the challenge is something that we don't currently address. We just use existing agricultural models. The first part of the challenge is really a object detection problem. There's some twist to the object detection problem there's some, we have a deep learning solution around it. There's some tweaks that we employ. We also integrate that with an out of distribution detector and so on. The pests are very, very tiny, so you need super resolution techniques to identify them. But other than those tweaks, it's fairly standard. You can see, the AI model drawing little bounding boxes around the pests that are of interest. Here, in fact, there's two types of pests, and if you can see, there are these faint orange boxes as well. It's distinguishing between the two types of pests. So this is just sort of an anecdotal example of performance. The overall performance is in the table there. We look at sort of false alarms for, the way we measure performance of an algorithm like this is whether it's correctly identifying, the threshold of pests in order to spray pesticides, or it's wrongly identifying. So that's what we call, that's the difference between a false alarm versus a missed alarm. So those are our false alarm and missed alarm rates currently. And we are in the process of piloting this in a cotton farm in Maharashtra. This was in fact funded by Google. The last solution that I'd like to talk about, there are a number of other things we are doing, but I'm going to run out of time pretty soon, is a solution that was, is a problem that was brought to us by the Gates Foundation. And the problem is a simple one. The problem is that newborn babies in villages across India, and this is even true in Africa, their weight isn't measured accurately. And the reason their weight isn't measured accurately is going to be evident. So for example, here is a register that an ASHA worker uses where they record the weights of newborn babies. They go home to home in a village and record the weights. And you see a number of these weights are 2.5 kilograms. The reason they're 2.5 kilograms is because 2.5 kilograms is the WHO threshold for low birth weight. So if a baby is lower than 2.5 kg, they often round it up to 2.5 kg so that additional interventions don't have to be done. I mean, it's not their fault either. They're highly overworked and they don't want to do additional interventions and follow-ups and so on. right? So it's often rounded up to 2.5 kg. So this is a huge problem. What you need here is an automated system that takes the weight and logs it in the back end without human interference, right? So here's how it's currently done, right? You have, I hope all of you can see the video. You have a baby that's put in a sling, or I mean, the sling is actually quite sophisticated. Often it's a sari, and then this ASHA worker has a spring balance that's attached to the sling, and the mother is somewhere in the background. There's another person helping her, and they eyeball the weight, right? And just looking at the video, you can probably tell this is an extremely error-prone process. Right? The baby can be moving, the spring balances are not well calibrated, and so on. Right? So what we've done here is something that we call a virtual weighing machine, which is just using a simple smartphone that the ASHA workers are given by, the government. We use a very basic smartphone to take either a series of pictures. The method actually works reasonably well even with one picture, but it's ideal with a short video of say 10 seconds or so, where you take a video that spans the baby at various angles, and then the video is input into a deep neural network where a full 3D reconstruction is done of the baby, and then the 3D model is measured. So it's measured in software in the sense that we measure the volume of the baby and then multiply by density to get the weight. It turns out that baby densities are fairly constant across the world. So this is something that really we use to our advantage. Of course, once you have a 3D model, you can measure other parameters that are of anthropometric interest, like the head circumference, the length of the baby, the stomach circumference, and so on, right? These are all health-related parameters. So this is just an example where we input a video. This is sort of a simulation. It's a simulation. This is not a real video. We sort of created 3D babies in simulation and put checkerboards on them for scale. And then there's an inferred 3D model versus the ground truth model. And in this case, you can see the inferred model does pretty well. And this is sort of a range of predictions for babies in a hospital setting. This was done in Nilofer Hospital in Hyderabad, where actual weights are compared to predicted weights. And the blue silhouette you see in these pictures is the inferred model by the deep neural network. The other areas that are of interest to us, that are some of them are ongoing, some of them is work that we are planning in the future. In the healthcare space, we're looking at maternal and child health. We are particularly interested in pregnancy risk stratification, being able to identify in advance if a mother is going to have complications with childbirth. There's work that we've already done and still in process to some extent on HIV, on adherence to HIV medication regimen. This is also an area where we have promising results, very similar to the TB adherence work that I showed you. We are doing a lot of work on COVID at the moment. We're doing forecasting for Mumbai City. We're engaged very closely with Mumbai City, and we have a data sharing agreement with the city. So there's data exchange going on, as well as modeling and epidemiological modeling and forecasting from our end. The really new thing we're doing is using rigorous techniques that were developed in machine learning, bringing them to epidemiology, and then using them for both model fitting as well as uncertainty estimation. We are also developing a cuff-based screening solution for COVID. So this is work in progress. In agriculture, the general areas we're interested in outside of farming, outside of cotton farming, is e-markets, automated farmer advisories, and there's a very broad area of water management where a number of AI techniques could potentially help. So I want to end with the framework that we use to evaluate problem areas and then eventually design solutions. We have this 7-question framework that we apply to problems before we decide to work on them. And the questions are, in a sense, they're obvious, but it's useful to have such a framework when we think about problems in the social space. So obviously, the first question we ask is this a big problem? The second is there an AI solution to this problem? The third is, will solving the AI part make enough of a difference? If there are many problems out there where you don't really need AI, where very simple decision systems can make a huge difference. Will the solution be accepted by stakeholders? This is sort of a precursor to deployment, because deployment is a very complicated process in the social sphere. Does data exist? That's an obvious one. Are there partner organizations? And this is related to previous questions. Are there partner organizations who can co-create with us in the sense of data sharing, problem identification, and so on? And then other partner organizations who can help us pilot and scale. So I'd like to end there. Thank you very much. Happy to take questions.
Thank you, Dr. Raval, for giving us a detailed overview of what Wadhwani has been doing in the sphere of artificial intelligence, and especially in the sphere of social good. There were certain very interesting slides on tuberculosis and how it is being taken into consideration considering the Indian landscape. So we just quickly look at some of the questions. There are not many. I think most of us are people are hungry, seem to be. So so one is a very generalistic question which has been asked, that how AI, I think they need to be a little specific, how AI can be useful in the poorest of the poor sections. Like maybe they are trying to target, the audience is trying to understand how AI can be useful in the rural areas. You did show some slides related to that. Basically, I think that has been more or less addressed. There are other questions related to, okay, I would classify any solution aimed at the poorest section of society as a critical system. If the worm detection in cotton went wrong, it could lead to a farmer suicide. Yeah. Given the unexplainable nature of most, do you think we should tread this path? So this is one question. Do you want to address, or should we look at?
Sure. So this is actually one example of a much broader question that Taposh also addressed: the whole risk of deploying AI systems in cases where it can impact people's lives, right? This is not just true for agriculture, also true for healthcare. And really the only answer to this is doing very, very rigorous model evaluations in different population cohorts in different areas, and then starting small, right? So you want to make sure that you pilot and test in very, very small populations and then scale gradually. And explainability is a very important component. We need to we need to figure out ways to be able to attribute mistakes to certain aspects of the algorithm. So we are actively working on explainability for all of our models, but this is a very important criterion.
Okay.
And the other aspect of this is also statistical averaging, right? So if you, for example, in the cotton context, if you base your inference on a single picture, that's not going to be robust. So if you do averaging across multiple pictures taken within a span of, say, 2 or 3 days, or even within the span of a single day, multiple pictures taken across one farm or across multiple farms, and if you do averaging, your predictions are going to be more robust.
Right. Okay. There's one technical question that has been asked. Neural notwithstanding can recreate the shape, but do you also measure the height and width, since the picture taken from different distances might potentially lead to different weight measurements?
Yeah, that's a good question. So this is why we have a checkerboard in the frame, is really to provide an overall scale for the inference. We also find that even without a checkerboard, you can often, a baby, a smaller baby is not a scaled version of a larger baby. The shape is actually different. And the AI model can pick that up and figure out what's the correct sort of scale to assign to that baby. But having a checkerboard improves the accuracy.
Okay. So I think we'll take the last question in all of the slides. If we replace machine learning with computational use, seems unwarranted. Okay, I think more or less most of the questions have been addressed. So with this, we come to an end with this pre-lunch session. And thank you so much, Dr. Raval, for that very insightful talk. We got to know various facets of Wadhwani, what does it does in that sphere of AI and social good. And it's very, 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 very enriching.